We are going to do a presentation today on the understanding the movement of the fetal head through the maternal pelvis at the end of pregnancy and in labor. And we're also going to do a deep dive into understanding the movement of the cervix and how that changes. I have some slides to share with you. Okay, so we're going to go into a conversation about the fetal changes, but first I want to introduce myself. My name is Augustine. I'm a midwife of 20 plus years. I have a master's degree in maternal child health systems from Bastyr University. I have founded and run many birth centers of my own, and then I also help other birth centers become successful around the globe. I teach midwifery, and I'm speaking in a few conferences coming up. If you're in the US, I will get to see you. We have the online conference of the Global Alliance of Independent Midwives in May. There'll be more information coming out about that. And I love to mentor new midwives. You can follow me on Instagram or Facebook at Midwifery Wisdom. And I'm really happy to share some knowledge and some expertise with everyone. So welcome. Welcome to everyone. I have a podcast on all platforms called Worldwide Midwifery. And if you know someone who should be interviewed for this to showcase an amazing part of their world, midwifery in their region, please let me know. You can follow that on Worldwide Midwifery. Okay, so we're going to talk a little bit about like an introduction to guiding principles about how I like to teach about midwifery and what I believe. So first of all, I really believe that midwifery can be sustainable. It can be sustainable for the midwife so that she can continue to do this work into the future. It can be sustainable for both mom and baby. In other words, not only do they live, but their lives are not radically changed as a result of that. I also believe birth can be sacred. It is one of the peak human experiences. It is a process where a woman is born as a mother, a person is born as a parent, and a family is born in the process. And that is a sacred journey. It's a rite of passage in our lives. And I also believe that the whole process can be safe, and safe for the mom, for the baby, for the family, for the birthing person, and for the midwife as well. There is so much talk about how midwifery is not safe for the midwife. It's a dangerous experience to practice feeling like you're going to be investigated or sued, or like somebody is going to endanger your life as a result of practicing. So that's a very scary situation, and we want to avoid that. I want everyone to know that I believe that perception is 9/10 of understanding. We can only understand that which we perceive. So the goal of this training, and in fact of any work, is to expand perception so that we can understand more and more. And so I'd like to invite you to sort of suspend any previously known beliefs about how this all works, and really be open to whatever unfolds, be open to new information or new learning in this training, with the goal of opening your perception about what's possible. So let's talk really quickly about the focus of midwifery. So I really believe that there are three main focuses of midwifery, and we have neglected the fourth for a long time. So you might know midwives who are very focused on the mom, very focused on the baby. You might know midwives who are very focused on themselves. No one of these focuses is wrong to get your attention, to bring you into the profession, but they become myopic and they become dangerous if we stay focused on just one of those ideas. So we do need to take care of ourselves in this process. We do need to eat and sleep and take breaks. We do need to take care of the mom or the birthing person and the pain that they might be in, or their physical needs. And we do need to take care of the baby, monitoring heart rate, making sure that they're tolerating the labor. But we can't do any one of those things exclusively. We have to do the process. We have to balance the process, if that makes sense. So what we're looking for here is balance. in midwifery, where we are balancing the practice, the focus on the mother, the baby, and the midwife. And this will change slightly depending on what birth you're at or what birth you were just at, how your focus, how much sleep you've had, all these things, what the mother's needs are, what the baby's needs are. But we're going towards the balance, and we don't want to ignore any one of these focuses. So a lot of times in midwifery, we're ignoring ourselves and our own needs, or some midwives are really focused on ignoring the baby. They're really focused on the mom's pain or the mom's experience, and they stop taking heart tones, or they're really focused on the baby, and they will ignore the mom. That's what happens in modern day obstetrics a lot. But we have to ask ourselves, what do you gravitate to? What's your normal focus? And then how can we find balance in every birth and in every situation? So what I want to talk about now is the practice of midwifery. So this little infographic between normal, natural, and safe, to me, makes up a really good description of all birth. All of birth, every part of it, every potential and eventuality fits in this little infographic. So let's break it apart for a second. What we're trying to do, of course, is help birth stay in that elusive little center, that we call that butter birth, where everything is normal, natural, and safe, where you just get to sit back and smile, and a baby slips out easily. But that's actually the smallest part. We have to understand our balance and to understand our boundaries. We have to figure out what part of birth we are comfortable attending in the community setting. So I use this infographic to help tease that apart. So there's birth that is both normal and safe, where these two overlap, but it's not natural. And in a scenario where birth is both normal and safe, but not natural, is a lot of hospital birth. So women birthing in the hospital, they might be monitored, so we know that there's a safe experience happening. They might be having a normal course of labor, but it's not actually natural. All manner of medication might be given. There's birth that is normal and natural, but not safe. And I think that a lot of midwifery birth actually fits into this category. There isn't good monitoring, there isn't good backup or support or supplies. And so it ends up being a normal birth that is natural, but there's questions about safety. If we don't take heart tones but every hour, that's actually not safe for most of labor. There's birth that's safe and natural, but not normal at all. And we have these scenarios sometimes. We might be monitoring closely and baby's doing well, but she's pushing for many, many hours because of a malpresentation. It ends up being natural and it ends up being safe, but it was not a normal course. Breech might fall into this category. Then there's birth that's safe, but not natural or normal. And I would say there are times when this has to be a part of birth. Like, for instance, somebody who has a placenta previa. If the placenta is covering the cervix, obviously that can't come out first. That's life-threatening to the baby. And so we have to have a cesarean for that. That's not natural or normal, but it is safe. We have birth that's normal, but not safe or natural. And this is honestly a lot of hospital births, a lot of obstetrical births. They're induced, they have lots of pain medication, all kinds of other things. But shift change is happening and nobody's really paying attention to their emotional, psychological safety. And it's certainly not a natural birth, but birth still works. So it unfolds normally, which is kind of amazing. And then there's birth that is safe, that is natural, but not safe or normal. And I think there's a lot of birth like this on YouTube. You might see those birth videos of women birthing unassisted with dolphins and things like that. It's very natural, but it's not safe or normal in a lot of ways. So this is kind of how I think about the balancing act of the practice of midwifery. And we need to always make the order of decision making be that if we have to give up one thing, we're going to give up natural in order to stay normal and safe. And so if we have to give up two things, we're always going to give up normal so that we end up always defaulting at safe. Yeah, hopefully that makes sense. We create the sustainability in the practice of midwifery. We're finding balance. We're having an integrative, collaborative care within a larger health system so that we keep that safety. We reduce our personal liability, and ultimately safety should be everyone's bottom line, because safety is the mom or the family's bottom line. So your question is, what part of birth are you comfortable practicing in? And because midwives don't generally have the ability to do cesareans, we're not going to be doing safe only births. Because we want safety to be a part of it. We're probably not going to be doing normal or only natural births. We're probably going to be somewhere where the lines overlap. And so the question is for you, like, what part are you comfortable with? All right, so hopefully that makes sense. We're going to jump into content now. So here we are. We're talking about what's happening in there. One of the most complicated parts of midwifery is that elusive cervical exam, and plotting those, understanding what's physiologically normal over time is the question. So this is a particularly challenging assessment. It's complicated 3D relationship. We're talking about relationship of babies' bony and soft structures to mothers' bony and soft structures. It's constantly changing throughout labor. It can only be measured in the dark. And all the teaching models are wrong. So I'm going to give you a few examples of the poor teaching models that we have and let you know why it's so frustrating. So first of all, here's a great example. That is not 100% effaced. That's more like 50%. The cervix doesn't open in a circle, so that assessment is incorrect. And then, the bottom picture here, the vaginas don't hang open like with all the air on the inside. So like, that's not what really happens. Here's another great example with like a 10-pound toddler in an OP presentation. That's not how station is evaluated. Again, vaginas hanging open. This isn't what happens in real life. Again, the circle, there's no such thing as a circle in a cervix. It's actually like egg-shaped, and it doesn't open evenly. So this is all incorrect. Also, much of the language around teaching this is incorrect and or misleading. Like this one where the cervical canal is obliterated. Yeah, that's not what happens to my cervix. I don't know about yours. So these are all just really challenging. Here's another really crazy example where the cervix is getting fatter as it goes to 10 centimeters. And of course, that's the very of what's happening. So these are just very linear, non-accurate drawings. Anyone who's actually done a cervical exam can tell you this is impossible. That's more like 6 centimeters. You cannot open your fingers to 9.5 or 10 centimeters. That's not possible. So it's just a really poor representation. Here, this is a little better at least. We can see the cervix, the drawing here of the cervix moving from posterior, and that is what happens. And of course, this station drawing at least has a baby in an OA presentation, which is generally how it happens. So that's a little better. But let's kind of talk about this 3D relationship, this movement of baby, cervix, and pelvis in labor and birth. So it's very complicated with many moving parts. So let's kind of break each of these apart. We're talking about pelvic shape, right? There are 4 recognized shapes of bony pelvis structures, but there's so much more to that. There's alignment. So throughout the course of your life, with falls, car accidents, abuse, trauma, we can have alignment be off of the pelvis. So it's so much more than the actual bony shape. It's the alignment, and the alignment is impacted greatly by the pelvic ligaments and or their mobility. We also have cervical ripening, effacement, dilation. That all changes during labor. Fetal station, of course, how low the baby comes in the pelvis. Fetal position presentation, and flexion, attitude of the head. Syncliticism or asyncliticism is another piece we'll have to assess with the baby's movement. And then, of course, the baby is moving and rotating through the pelvis. And then the soft structures and the bony structures of their head are molding or changing shape. So as you can see, this is a very complicated 3D relationship that changes over time. So you can't learn it once. You have to learn it in all the various angles of normal and abnormal to be able to correctly assess and then hopefully make changes. So let's break this apart. We're going to talk about the pelvis first. So the pelvis has the big hip bones on either side. It has the sacral bone in the back, and it's connected in the front tissue at the pubis symphysis, or the bony pelvis, the pubic bone. The pelvis does not lay on the sacrum like most drawings. It is upright and tilted forward, like in this drawing. And so the baby's pathway through the pelvis is curved. And this is called the curve of Caris. And we have to think about the three planes of the pelvis. The inlet is an oval side to side. The central part of the pelvis, or the mid pelvis, is an exact circle, and the outlet is an oval front to back. So we need to think about these different shapes to imagine more about how your baby rotates through the pelvis. And we'll come to that when we get to baby's head. We also have to talk about the joints of the pelvis. So we have a sacroiliac joint in the back that connects the hip bone to the sacrum. We also have a pubic bone in the front where connective tissue holds the pubic bone together. And all three of these joints become more mobile in the end of pregnancy and in labor. And this mobility is partly determined by the hormones of pregnancy. Relaxin is the hormone that helps to soften and loosen these connective tissues, these ligaments. Here's a side view of the pelvis, because I really want to drive home the idea that the pelvis is always tilted forward compared to most of the drawings that exist in midwifery education. So if you have a pelvis in front of you, you just play with your own body, you can stand up and feel how, in order for you to stand upright, your hip bone needs to be in alignment with your leg bone, and your spine needs to be sitting over the joint as well, which means that the sacral joint is much above the hip bone and the pubic joint is much below the hip bone. So if you find your own pubic bone and then put your hand into the curve above your sacrum, you'll see that your pubic bone is lower than your sacrum. So whenever we're thinking about fetal positioning and babies settling into the pelvis, we have to imagine that the pelvis is upright, tilted forward, right? We also have to think about the ligaments of the pelvis. The ligaments of the pelvis play a massive role, not only in the pelvis mobility, but also in the space available for the baby to descend in. So we have ligaments across the back of the sacroiliac joint. The anterior sacral ligament is one that plays a huge role in the mobility of that joint. We've invented all kinds of techniques to help soften and loosen that ligament, like the sideline release, if you're familiar. We also have ligaments around and across the pubic arch in the front. And then the anterior superior iliac spine connects to the pubic arch with the inguinal ligament across the front of the abdomen. And if any of these are over tight or have a history of injury, we can have a hard time with the baby even descending or rotating into the pelvis to start labor. Then there's a whole collection of ligaments across the back of the sacrum, across the low spine. And these affect the sacrum ability to move out of the way of the fetal head descending. So if you've looked at pregnant women laboring who are naked, you can look at their back and see a triangle or even a big diamond arise on the back of the maternal spine. That's called the rhombus of Michaelis. And this is exactly what we're picturing here. These ligaments would soften and loosen and then rise as the fetal head displaces the sacrum. So these ligaments, if they are over tight or injured, or if there's a history of sexual trauma or abuse, it's very hard for these to soften and loosen, specifically the sacrotuberous ligament, that connects the sacrum to essentially the pubic bone in the front. So we want to make sure that we know how to assess these ligaments and that we know how to release them in the end. And that frankly takes a big involvement in interprofessional collaboration. A midwife needs to learn much of the details that come from chiropractic or physiotherapy, that come from massage therapy or craniosacral therapy, osteopathy. There are many, many professions that have devoted themselves to understanding the anatomy and physiology of the pelvic, hard, bony parts, soft parts, mobile parts, ligaments, muscles, all of that. So get that training wherever you can. Frankly, going into that training is beyond the scope of today, but definitely collaborate with other body workers that you know that understand this incredible work. So we also have to think about the fascia. So the fascia of the pelvis is essentially the connective tissue that runs through our whole body between muscles and to ligaments. And so if you've ever worked with meat, if you've ever cut a chicken breast, you'll see that white, shiny, membranous fiber, and it's kind of like a sheet. So fascia comes in sheets, and these sheets run through the muscles, around the muscles, through and around the ligaments as well. And if the fascia is injured, bunched, it oftentimes will take nerves with it, and it will bunch nerves. So this is how we have trigger points or pain points in the labor, in the pregnancy. Oftentimes a baby is laying on or putting pressure on a fascia bundle. So we want to talk to women about massage, about self-massage, as well as body worker work to help soften and release fascia bundles. It makes for a more comfortable pregnancy, and it makes for a much more likelihood that baby will descend and rotate appropriately. So assessing fascia is another part of this job. And then we have the musculature of the pelvis. The muscle of the pelvis impacts the baby's descent as well. And so I just want to make a quick comment in this part of the hyper focus on cutting the muscles to allow the baby out. This is called fascia. This is called episiotomy. And episiotomy should be almost never necessary. I know that it is common use in this area of the world, but it actually creates long-lasting damage and potential dysfunction in the woman's sexual life. So we want to do everything we can to avoid cutting these muscles. Now, the episiotomy is an emergency technique to free a stuck baby who's crashing, whose heart rate is not tolerating the labor. And so it should go in the same category as cesarean. If the baby's not tolerating the labor and is not visible, we need to remove the baby by C-section. If the baby is not tolerating the labor and is visible, we can remove the baby with episiotomy and or forceps or vacuum. But that is an emergency skill, an emergency technique. It should not be routine by any means. We should develop the patience that it takes to allow these tissues to stretch naturally so that that birthing person can retain their full body integrity and their full function postpartum, as well as be allowed to heal without excessive pain. So just a note there, you'll see that the muscles around the vaginal opening are kind of in a circular motion, and the muscles around the anal opening are kind of a circular, and together they form a figure 8. And this figure 8, where it meets in the center with the superficial transverse perennial muscle, the bulbar cavernosus, all come together in the center. This is a crucial part, not only for that woman's sexual life, but also for the integrity of her entire pelvic bowl. So there's a huge reason not to sever these muscles artificially, because they support all of the organs above them. So the whole pelvic floor supports all of the pelvic organs and even the abdominal organs. So keeping those intact, and certainly if they do have an injury or if they do need repair, knowing how to repair properly. And again, that's outside the scope of today's workshop, but definitely a huge part of midwifery as well. So then we're going to talk about alignment and shape of the pelvis. So there are 4 classic pelvic shapes. But with so much of a mobile demographic, such a mobile population now, most people have a hybrid shape. They have a pubic bone, like a pubic arch from one type of a pelvis. They have a sacrum from another type. They have hip bones from another type. There are very few classic pelvic shapes anymore. So pelvimetry is just not as valid as it was 100 years ago when it was being developed. The idea would be that they would risk assess for a platypoid or an anthropoid pelvis and actually not plan a vaginal delivery with those clients. But that's just not valid anymore. And especially as we understand more and more about how actual ligaments of the pelvis, fascia of the pelvis, have such a more of an influence on the pelvic function than does the bony shape. It's just really not valid to risk someone out of a vaginal birth without a trial of labor. So pelvimetry is fairly inaccurate because of the hybrid pelvic shapes, and also because so much changes with the hormones of labor that you cannot definitively say who can and cannot have a baby vaginally before they're actually in labor. So pelvimetry should not be a major part of your practice. But what should be is being aware of the prominent features. So if you do an exam on this person before they deliver, you could examine the prominence of their ischial spines, the prominence of their sacrum or their coccyx, how high of a pubic arch they have. And these could kind of play into your idea of how this baby will fit out. You can also do an evaluation from the outside of their body pretty effectively. And this is just literally unobtrusively watching them walk. Watching your client arrive to their visit, move, and sit down can let you know if there's any tension points in their pelvis, if they have any tight spots. And then when you're touching their abdomen to check out their baby, you can feel for tender spots, for ligament tightness in the front of the pelvis. And sometimes I even feel in the back of the pelvis as well. You have to develop a bit of a relationship with your client before you start feeling their bum, but it definitely can help you evaluate what needs to be done in the pelvis during the labor. So let's talk a little bit about cervical ripening and effacement. Let's just pause here. Actually, I'm just going to come out and see if there are any questions so far, because we've gone deep into the pelvis, and I want to see, before we jump into the soft tissues, if there's questions or comments about what we're talking about so far. Anyone want to ask a question?
So Augustine, this is Riddhi. Hi.
Hi, Riddhi. Nice to hear from you. How are you?
Good, good. I had a question that, it's very common to hear CPD, that
Yes.
the pelvis is not proportionate and it happens before birth or even during labor. This is a very common reason for a C-section. So what can we do? What can be done about that? And
well, it's that diagnosis, instead of like failure to progress or like the diagnosis of failure on the birthing person's pelvis and anatomy, the diagnosis should really be failure to have patience or provider failure. That should be the actual diagnosis, right? So CPD, cephalopelvic disproportionate, is a real thing, to be perfectly honest. CPD can happen, but it almost always relates to malnutrition in childhood that created a malformed pelvis, or from car accident or some kind of pelvic injury that caused an actual shape change. The likelihood that a baby won't fit out of a pelvis in the body that grew it is very, very small, and it relates usually to abnormal injury. Now, with that being said, there are many babies that need to be born by cesarean because they are so deeply wedged in the pelvis in an abnormal position that they cannot rotate. And so there needs to be a lot of special attention to women at the end of pregnancy to help them get a baby in the anterior part of the pelvis, the occiput anterior. So a baby who is stuck in the posterior, called occiput posterior presentation, or OP, sometimes called face to pubes or sunny side up, A baby who's stuck in the OP presentation is at high risk for cesarean. In fact, a third of all cesareans are done because the baby is in this abnormal, poor presentation. You can almost think of it like a square peg, round hole. Like, it's not actual cervical-pelvic disproportion, it's positional disproportion, right? So when the baby is poorly positioned, they sometimes can't fit through the pelvis. And that happens a lot. And I think that happens more and more recently because of our increasingly sedentary lifestyles, and because of this imported westernized way of relaxing, which is like leaning back with your legs up, which is like the very worst position for a pregnant person to be in, because we tilt the babies back into the back of the maternal body. So this is a whole nother topic. Optimal fetal positioning in pregnancy is a whole nother topic, and I would love to go do another presentation on that. But today we're just going to go into the structure and how it relates together. But just to answer your question, Dr. Reddy, ultimately it takes preparation and patience. So you might have heard of the 3 P's in obstetrics before: passenger, passage, and powers. So this is the old obstetric definition of the influences of labor: passenger, the passage, and the powers. But I would add 2 more. So in my 3 P's of influence of pregnancy, I add to passenger, passage, and powers, I also add psychology, which is kind of a P, because the mother's own fear makes a huge difference. Her preparation makes a huge difference in the process. And then I would also add provider, which is definitely a P. So your provider influences the outcome extremely. So when you're thinking about dysfunction, like you're in a labor and you're like, this is not progressing normally, what's going on? These are kind of the 5 P's to check in on. Is she afraid? How is her psychology? How is she prepared for this? How are the strength of her contractions? So obstetrics times to just like put more oxytocin and run more and more oxytocin. But if the baby's in a bad position, so if the passenger is in a bad position, there's no amount of contractions that will change that, right? We have to do actual physiology to change that. And then obviously that very rare occurrence where the passage is malpositioned. And then provider, the kind of provider you have attending your birth totally changes your birth. So for all of you interested in more natural birth, interested in physiology, interested in more gentle birth, patience is going to be a huge part of the skill set. Being able to sit with women as you work to reposition their babies, sit with them for as long as it takes for a normal labor to unfold. And of course, the challenging part there is that differentiating between normal and abnormal. And again, that's the complexity of midwifery. So hopefully that gave you a little more insight. As we get deeper into baby's position, I think this will make more sense for you. Any other questions before we move on?
Yeah, I do have a question.
Please.
Like sometimes in pregnancy, women complain about pelvic pain, right? Does it at that time itself it indicates that there is some ligamentous issue that we can correct and also help position the baby in the right way so that in labor also helps the mother as well as the baby?
Absolutely. So pelvic pain in pregnancy can be either related to a pre-existing issue. They had a car accident before, they have sexual trauma or something that's pre-existing, or it can be related to fetal positioning. And so sometimes it's both. And so, like the generic answer is, we definitely want to do everything we can to reduce pain. Moms get tense, everyone, but when there's pain, you get tense, and where there's tension, there's lack of movement. Where there's lack of movement, there's a way to impinge the baby's movement through the process, right? So soft, juicy, open, relaxed. That's the goal, to have a normal labor. And so if she has pain in pregnancy, that's definitely something where her body is saying, help me, I'm not comfortable, right? So any amount of body work, massage, cranial sacral, osteopathy, chiropractic, acupuncture, osteopathy, like any kind of manipulative therapy that she likes and knows and is available in her community, it would be great. You as a midwife can teach her very simple self-stretch, self-massage techniques that can make a huge difference in her comfort. Being mobile every day for 20 or 30 minutes with a walk or some kind of yoga or exercise program is highly recommended, even from the beginning. I know some people are afraid of exercising in first trimester, and that's not really a thing. You can totally be active. And also rest, encouraging them to rest smart on one side or the other with a pillow between their knees and under their head and under their back and under their belly, and just like fully supported full body relaxation is important. And then as you become more and more knowledgeable about the function of the pelvis and how it relates to the baby, you can give more and more suggestions for how to get a baby properly positioned. But yes, it should be addressed. There's also all kinds of support garments that can help support that process, like an SI belt for pubic pain, sacroiliac belt. And it's just basically a really tight band low around the pelvis that kind of holds the pelvis together. That can be a huge benefit, a huge help. And then belly binding, if we have a rectus diastasis, which is a split in the abdominal muscles, that can be really helpful. But that is, the solutions are kind of a little bit later in this chat. So let's keep rolling on this. And if you do have a question, I do invite you to speak up. All right, so let's move into talking about soft tissue. So we're going to talk about cervical ripening and effacement. So without ripening and effacement, labor is literally not possible, which means with a non-ripe cervix will fail, full stop. So ripening is the change from when the cervix feels like the tip of your nose to feeling like your lips. So you can push on yourself right now and even feel how firm your nose feels compared to how squishy your lips feel. That's the process of ripening. And that is precipitated by hormones in the maternal body. So we can increase the rate of hormone production at the end by encouraging her to do all kinds of things that make her feel nice, make her feel juicy. Laughing at funny movies, getting massage, hanging out with people she loves, kissing and smooching with her partner, all of these things, if they make her feel good, will help release those hormones that soften and loosen the cervix. The way that cervical effacement is measured is as a ratio percentage from term or from early pregnancy to now. So early pregnancy cervix starts out 4 centimeters or about 2 inches, and then it decreases in thickness throughout the course of her last month of pregnancy. Some OB units use the term 0 to 3 or use 0 to 4. Some use the 0 to 100%, but it is impossible to get more specific than, I would say, 10 or 15%, and honestly, even 25%. Sometimes you can't be more efficient at assessing cervix than all of it's still there, 3/4 of it's still there, half of it's gone, 1/4 of it's left, and then it's all gone. That's about as specific we can get with effacement. Imagining that we're going from that 4 centimeters down to paper thin. So most women are at least 50% effaced at term, even primates. If they're not, that's a reason to work on cervical ripening before we try to get a labor going. Most primates will ripen and then efface to almost 100% before dilating much past 2 centimeters. But multips, people who've had babies before, will efface and dilate at the same time until they're about 5 centimeters. And then they will finish effacing and then finally open. So effacement can be triggered by using your hand. So I'm just going to show you this demo because it really helps a lot of my students. So if you put your hand upright facing the ceiling and you let your thumb match that, your examining fingers can feel into this space. And that space right there is about what 50% feels like if you've never felt a cervix. Versus if you pull your thumb completely straight, this webbing here is what 100% feels like. So obviously it would be in a circle, but we can't really demonstrate that. But if you did an exam, went in and felt the cervix, it would feel like that when it's 100%, and it would feel like that when it's 50%. So hopefully that's helpful to you. So this is sort of a very crude drawing, but it gives you a little more of an insight. The prima gravida or the nulla gravida woman will have this long, thick cervix in the beginning of her last month that's equally closed in the front and the inner os and the outer os. versus a multip whose outer os may open sooner than the inner os. And that kind of funneling is what we call it in the multip cervix, is what I'm talking about, when she may open bigger before she's actually thinned at all. Okay, so let's talk about dilation. Dilation is when the cervix is opening. It cannot open until it has thinned all of the way. And the cervix opens like an egg with the pointier part up by the pubic bone. So that means that an anterior lip, unless it's swollen, is really just the last part of the cervix to melt back. So if we checked all women at exactly the right time when they were 9 centimeters, we would feel a lip on everyone. So edema of the cervix is not normal. It's always a reaction to a malpresentation of the baby. Let me just say that again. If the front of the cervix is a fat lip, not thin like the webbing of your finger, but fat like your actual lip, that means it has edema in it. It's swollen. And the only reason that a cervix gets swollen is if it doesn't have even and steady pressure on it. And the only reason it wouldn't have even and steady pressure on it is because the baby is not positioned correctly. Ergo, a fat cervix is always related to a malpresentation of the baby. Okay, so let's just go to this centimeter piece, and I'm gonna just show you this image really quickly. So on the left, this old image of how cervix is open in a circle is incorrect. The right image is correct. Cervix opens as an oval, like an egg, not like a circle. So the pointier part of the egg, the top of this drawing, is by the pubic bone, and the collection, like the accordion shaped back, is in the posterior of the mom. Hopefully that makes sense. I know it's so much, but I'm going to come and talk to you for a second. Hi, friends. So what I want to talk to you about is this dilation piece, and I want to hopefully answer any questions that you have. So this way that we have talked about putting centimeters attached to the cervix change is really crazy. I mean, I just want to name this. If any of you are having trouble figuring this out, this is why. It's really crazy, right? It's really crazy that we attach a number to an organic change that happens in the dark that can only be measured by different shaped fingers. It's really erroneous. So I would like to propose that we just standardize the measurement of the cervix by thinking about it more in anatomical landmarks. So when we do a cervical exam, we only have our own fingers and the maternal body to compare to, right? So let's look at this way. So if you go do an exam and it just admits the tip of your finger, that's 1 centimeter. If it admits your whole finger, that's 2. If it admits your whole finger with space, that's 3. If you can fit both fingers in, that's 4, right? When you can fit what we call the V in the tree, that's 5. And then we go backwards. So if you do an exam and there's no cervix in the front or anywhere all the way around, that's 10. If you can only feel cervix in the front, that's 9. If you can feel cervix all the way around the baby, that's 7. And somewhere between 5 and 7 is 6, which is why all women get labeled as 6 when they get admitted to the hospitals, because there's no anatomical landmark. Also, this is I'm digressing a little bit, but specifically for Meghna and Sneha, my students, I want to tell you, when you measure the diameter of the newborn in centimeters, or the circumference, you can find the diameter by using that pi formula that probably no one remembers because it took me a while, but you can find for the diameter, and the diameter of the newborn baby's circumference is how much she dilated. So if you take some of your recent baby's head circumference and you find the diameter, you will find that most babies over 3.2, 3.3, their moms had to dilate to 11, 12, 13 centimeters. So like, this is again, kind of out there, kind of a concept, but this is why so many women arrest at 6 centimeters, like their failure to progress gets diagnosed at 6 centimeters, because there's no anatomical landmark to 6 centimeters. So what happens is all the extra centimeters that they're having to dilate for their larger baby gets mushed into that space. So they're actually dilating 2 or 3 or 4 centimeters, all under the guise of 6 centimeter dilation. And they arrest in progress because they don't go quickly through that phase. And so if we had a better understanding of how the cervix is not related to centimeters, but related to anatomical landmarks, and how some women need to dilate more than our arbitrary 10 because they're having bigger babies, we could have a lot more patients with longer labors. So hopefully that makes sense. Any questions about that? Yeah, Dr. Kavita? You have one?
Yeah. So,
Yeah, go.
sometimes, the cervix doesn't dilate totally. Sometimes it dilates one side rather than both the sides, right or left. So again, that represents malposition of the fetus. Am I right? Or?
Exactly. Yeah, exactly.
Okay.
Very occasionally, it can be related to over tight ligaments on one side because of a history of injury or history of trauma. But most of the time, it's related to a malpositioned baby. So if you're seeing only one side melt away, that's the side where there's good heavy pressure, which means that's the side where usually the back is, and the side where the face is usually where there's lack of pressure. And so what you'll want to do is try to help that baby rotate into the position that will help the other side go away as well. Okay, so position, lie, and presentation. The lie refers to relationship of the long axis of the fetal body to the long axis of the maternal body. So the baby can either be longitudinal in alignment with her body, transverse, or oblique. The presentation refers to the lowest bony part of the baby in relation to the maternal pelvis. So that's either a vertex or a breech. And then position defines the direction of the presenting part. So at the baby's vertex, we talk about where the occiput is pointed towards the maternal left in front, towards the maternal left in back, et cetera, et cetera. And if the baby is breech, we're talking about the position of the sacrum towards the maternal left or right. The lowest presenting bony part of a vertex is the occiput. Of a breech, it's the sacrum. And of a face presentation, it's the mentum. That's the lowest bony part. The most normal is a longitudinal vertex LOA presentation. This is what we like to see babies positioned as, much more effective. Of course, some positions are much easier to deliver than others. A transverse presentation is an absolute reason for a cesarean, but transverse are quite easy to move. So if you diagnose it early enough in labor, you can oftentimes convert that transverse to a vertex. The leading bony part of the occiput is the occiput, and it determines the position. So this is what we call the fetal compass rose. So this fetal compass rose tells us how the baby's laying head in the pelvis. And so if we get that occiput anterior presentation with the ROA or the LOA here at the lower part of the drawing, that is the easiest position for the baby to be born in. But it is not the position that the baby descends into the pelvis in. So think back to our conversation about the pelvis. The pelvic inlet is an oval from side to side. So all babies descend into the pelvis in the ROT or LOT position. So they enter in the ROT or the LOT, and then they rotate at the mid-pelvis, either anteriorly or posteriorly. If the baby were presenting in the sacrum, the same is true. The baby enters in the RST or LST position and then rotates towards the anterior or the posterior. I do breech births and I do teach on breech births, and that's a whole nother workshop. And I do have that one online. So if anyone would like access, feel free to message me. But breech can be a variation of normal, just not preterm breech. and not breaches that are IUGR. The baby has to be appropriately grown and full term to be safe to deliver in the breech position. If the leading part is the bony baby is the mentum, because the baby is face presentation, the baby must rotate mentum anterior, which if the baby were not in the face presentation would be OP. So this is the only exception where that posterior presentation is better. Mentum anterior is the only way the head can fit through the pelvis and rotate under and around the pubic bone. Hopefully you don't have to do too many mentum anterior births, but mentum posterior is definitely a reason for a cesarean. There are more unusual positions, and the biggest one, of course, that I want to say in this situation is a shoulder presentation. A shoulder presentation cannot be born vaginally and must be a cesarean, especially if you have an arm prolapse. That's a real emergency, so get that to a hospital right away. But in terms of a frank presentation up on the left is the safest breech to deliver. So if you're thinking of doing breech birth, that is the one I would recommend experimenting with. Complete or footlings are more complicated. Okay, so occiput is the most normal, and the right two positions where the baby starts in the transverse and rotates towards the anterior, either left or right, is the most normal. Posterior is a pain in the back, as we all know. Sometimes where you're finding heart tones can give you the clue about the position you're getting if palpation is really hard, but not if you're using a Doppler, because a Doppler will give you an echo pretty much all over the belly. So you have to use a fetoscope, a Pinard horn, to get quite good at diagnosing position based on heart tones. Okay, so the big trick is taking the external palpation and translating it to internal relationship of structures, or vice versa. So each of these is over the feel it would be. So the baby on the left, if you palpated this baby in that LOT presentation, like the baby is drawn, then if you did a vaginal exam, this is likely what you would find. In the LOA presentation, you can see how you would feel that, and the LOP. And so you have to know the shape of the baby's head and the various landmarks of the baby's head. How they relate to the pelvis is this complicated piece. So before we move into baby, let's talk station. So station is the degree of descent of the fetal pole into the pelvis. It's measured as a relational estimate of the fetal pole to the ischial spine, and again, measured by touch in the dark without any standardization. So I want to reassure you, for the purposes of full-term low-risk midwifery clients, there are essentially only three valuable measurements. Is the baby above the mid-pelvis, at the mid-pelvis, or below? And that's all you have to know. If the baby's high and floating, you don't have to figure out a number. You can just literally document floating, and you can make your decisions based on that. And if the baby is below +1, you can see it in the depths. You can see it at the opening. So it's not necessary to write a number. You can write the anatomical landmark. Again, at the mid-pelvis, above or below. You don't have to memorize all these different numbers for station. It's not particularly useful clinically. If you were doing a cesarean and you needed to put in a bladder blade, this station could be useful, like -4 or -2. But for the purposes of midwifery, floating, above, at, below, or visible. Those are your measurements. Here's a great visual of how that baby starts to engage in the pelvis in that nice transverse rotating to anterior presentation. Both of these have a baby who is doing that rotation into the anterior. See how nicely that baby fits. And then once they're deeply engaged, you can see the baby at the vaginal opening, because that face fits along the curve of Caris, a curve of sacrum. So the pubic bone should ideally be fitting just behind the baby's occiput in the neck as it curves around the neck and steps out of the pelvis. Flexion impacts this whole process. How well is that baby tucked, chin to chest? The smallest diameter is when the baby is well flexed or well tucked. a deflex baby will oftentimes convert to a smaller diameter during birth, which is how face presentations happen. It's oftentimes determined by the roominess of the pelvis, the speed of the path through the pelvis, and often the amount of amniotic fluid. And it's not very predictive of success of the birth until the baby reaches 0 station. So here's these examples of flexion. So on the far left, you see a well-tucked, well-flexed baby with the crown of the head being the leading point. This deflexed baby, the next slide, and then a military presentation baby will oftentimes convert to a face presentation because it's such a smaller diameter. Here are the measurements just for you to picture. Face presentations are not comfortable for anyone, but they are smaller to fit through the tight space. So if we have a deflex military presentation, the point of contractions will either cause it to be more flexed with the chin toward the chest or more deflexed with the face presenting. Asynclitism is similar to flexion, and it's the articulation from side to side. Sometimes it's determined by the pendulousness of the maternal abdomen or the strength of her maternal muscles. Sometimes it's about amount of amniotic fluid. Occasionally it's position. But there's 2 types of asynclitism, anterior and posterior. And if the baby is tending towards the anterior, we need to bring the belly up and bind the maternal pelvis. And if the baby is tending towards the posterior, we actually need to drop the belly and the baby out of the back. So there's radically different actions to solve these 2 asynclitism situations. And we must know which type we're seeing in order to know how to treat it properly. Rotation is how the baby descends into the pelvis and rotates. Remember, all babies descend in the transverse and then rotate either anterior or posterior. Failure to rotate oftentimes results in the diagnosis of failure to progress or deep transverse arrest or CPD. It's a reason for many, many cesareans. Rotation typically happens from 0 to +2 station after full dilation. So if somebody's being diagnosed as CPD or failure to progress and they're only 6 centimeters, that is a failure of the provider, not the birth. Normal rotation is 25% of the circle. So if you can picture this, the baby starts on the transverse, it should rotate just to the interior, 25% of that circle. If the baby takes the long way around or the long arc rotation, they're going 75% of the circle. They're going through the posterior to come back to the anterior. And that's what makes for long, challenging labor sometimes, but it's absolutely possible. We had a baby yesterday, actually, who took the long arc rotation, and it was still only a 4-hour labor. You can tell based on the head position. So we're going to skip over Leopold's. Most of you are practicing midwives and you know how to feel that, which is great. And so let's talk about the cardinal movements here. So the cardinal movements are the movements that the baby makes through the pelvis. And all babies make the same movements unless they are malpositioned and having to invent their pathway to get out. So we start with the baby head down, floating before engagement. And on the left side of each of these tiles, you see the position of the baby. And in the upper right, you see the position of the head if you were to do a vaginal exam. So this correlation between position from external palpation versus internal assessment is a huge part of getting good at this process. So once engagement happens, the baby starts to flex and descend. And then in stage 3, we have this deep engagement. And this is usually when we go to 10 centimeters. So engagement, slide 2 is labor. Slide 1 is just pregnant. Slide 2 is labor. Slide 3 is transition and that final part of full dilation. And so 4 is when we begin pushing the baby out. So almost all dysfunctions happen somewhere around slide 3 or tile 3 here. Whether the baby is rotating from the transverse to the anterior or to the posterior, that's when that usually happens. The rest of the cardinal movements are very straightforward. In 4, you can see the baby in the depths. In 5, the baby's crowning. 6, the head is born, and then 7 and 8, both shoulders deliver. So you got to think back to this early rotation before the baby is or just at the mid pelvis. Let's talk about molding really quickly. The baby's skull is made of these different movable plates, and they're all connected by suture lines and fontanelles. The pressure of maternal tissues determine the direction and degree of molding. So right after birth, you can determine exactly what and how the baby moved through the pelvis by looking at the marks on their skull. So again, here's an example of the different plates of the baby's skull. The sagittal suture runs down the center and the top of the baby's head, and it connects the anterior and posterior fontanelles. And how those move during the labor can tell you, afterwards, can tell you what position they were in. So here, just look at this picture for a second. You can see that this baby is very deflexed, right? The space between the chin and the chest tell you this baby is deflexed. And so the leading point for this baby is the top of his head, which is abnormal. That creates abnormal molding that you can see afterwards. So on this picture, can you see how the direction is to the crown? The point, the leading point of this baby is at the very back top of the head, the crown. So this is a very properly positioned baby with the molding extending out into the back. Same thing with this baby. The leading point is way in the back. So you can see that the molding extends across the whole top of the head. This baby fit normally through the pelvis. So normally the biparietal diameter at birth is about 9.5 or 10 centimeters, unless the baby is significantly bigger than average size. And that's where the moms have to dilate more than 10 centimeters. Make sense? This is a really cool model that helps new midwives figure out how to determine position. It has a map of the fetal head. And if the mom is laying on her back when you do the exam and you match this to the exam, what you're finding, the top letters will give you the diagnosis of positions. It's a nifty little tool. You guys can find that. So let's do this for a second, especially Meghna and Sneha, my students. I'm going to call on you to participate. So in this newborn baby, you can see a little tiny divot right behind the forehead and around the anterior fontanelle. Can everyone see that? What would make that little divot right there? Sneha?
OP baby?
Yeah, so what bone made that pressure right there?
The pubic bone?
That's right, the pubic bone. So when we see a divot up behind the face, up behind the forehead, the frontal bone, around the anterior fontanelle, we know that for at least for some time, the baby sat in the occiput posterior presentation and the mother's bony maternal pubic bone put pressure on that frontal bone to cause that ridge. But the leading point of this baby's head molding is way in the back. So this baby came out OA, but took the long arc rotation as evidenced by that anterior mark on the head. How about this baby? Where's the leading point?
The occiput.
It's way, way in the back, at the crown of the head. So that baby was born OA, right? Occiput anterior. Do you see any evidence that the baby took the long arc rotation?
Not here.
I don't either. I don't see it either. Yep. And you can see that that chin must have been very, very well tucked for the leading point to be way in the back like that, right? So this was a properly positioned OA baby that was well flexed. And the leading point is exactly in the center in the back of the head. So this baby was synclitic. He was not tilted. He was exactly even. Yeah. How about this one? What do you see here?
It is more
See how
it looks like
it's more
asynchronous.
towards the side. Yeah,
yeah.
this baby was asynclitic because the leading point is off to the baby's right side.
Mm.
There's also in the top picture a divot at that anterior bone, but the leading point is still way in the back. So this baby rotated in the mid pelvis. So it was sat posterior, was asynclitic, but was ended up being born OA. Can you see it?
Wow. Yeah.
Yeah.
How about this baby? Basically almost
Transi-
no molding, right?
So
But the bit of molding was what? Who wants to speak up?
This baby was born OP. Direct OP.
Nope. Nope.
No?
There's no marks on the head. Do you see any molding that says OP?
so was this baby smaller?
Yes. Smaller, fast ride through the pelvis multip. Almost no molding, but the little bit of molding is pointing to the back. So this was a proper OA fast birth. Same with that one. How about this one? Can you tell which twin was first based on the molding?
Which twin came first?
Yeah. I know it's like a trick question, but it's not. So
Looks like-
if you knew that there were only 4 minutes between these babies born vaginally, one would have had a longer molding than the other.
Oh,
So which baby do you see more molding on?
On
The
right
left
side.
one?
on the
Left one.
yeah,
The
on
baby on the
mom's
left, the baby closer to us, right? Mom's right.
Right.
That baby has minimal but noticeable molding on the fetal skull. That baby, her labor was 1.5 hours. The second baby was 4 minutes, right?
Wow.
So you can see the order based on how much time the maternal body put pressure on the fetal skull. Yeah? Make sense? How about
That's
this baby? What about this baby? What's the leading point? Way, way in the back.
Are there
However,
two possible divots?
yes, do you see them?
Yeah.
Yeah.
Yeah. So the divot along the back is caput, and the divot along the front is molding from the pubic bone. So can you see the anterior mark, how the frontal bone is elongated? The anterior fontanelle is elongated with a little divot there.
Right.
So this is another example of a baby who took the long way through the pelvis. He was born anterior, but he took a long time to rotate. How about this baby? What do you see here?
So again, the back of the head, top of the occiput is the leading.
Yep.
There's definitely a divot right above the forehead.
Yep. So this baby was OP for 27 hours of labor
Oh, wow.
and finally rotated in pushing and was vacuumed out OA.
Oh,
Is it because of the vacuum? There's an elongated caput.
Nope, it's because of how much this baby had to mold to fit through. So she first molded into the OP with pressure out the top, and then she molded into the OA with pressure out the back. How about this baby? Can you see the difference? This baby also had to mold extensively, but never rotated OP. This baby does not have divot marks above the forehead.
Right.
Can you see the difference?
Yeah. It's smooth
Yeah.
like a
So
fruit.
this is just, what'd you say?
It's smooth like a fruit almost.
That's
Like a
exactly
papaya.
right. When it's smooth, it never had pressure on it. It had space. So this baby's head filled the sacrum like it was supposed to. and stepped out over the perineum without any bony pressure like the pubic bone. The pubic bone was at this baby's back of the neck the whole time, and that face was all in her sacrum.
Wow.
Does that make sense?
Yep, definitely.
So this is just a 10-pound primate. You see the rolls on the back of the neck, fat baby. Yeah, so it just had a lot of molding to do. That one you can't see very well. How about this baby? What do you see here?
So asynclitic led with the
Asynclitic.
baby's left.
Yep. So you can kind of even see the divot of the maternal pubic bone in that baby's temple, can't you?
Yeah.
Yeah. This baby was so tilted around the pubic bone, the head was molding around the pubic bone before he finally rotated into the OA and was born normally.
Wow.
Here's another example of asynclitic. Can you see how the whole head is shifted to the baby's left?
Yeah.
Yeah. Asynclitic. How about this guy? Where's the leading point on this baby?
Back of the head, top of the occiput again.
It's actually at the very top. Look at the top of the baby's head. The point of pressure leads to the top, not the back.
So the
You
circle
see that?
is the top of the head.
It's at the top of the head, which means that, see, the chin is not tucked. So this is an example of a baby born without being flexed. This is a deflexed baby. But is there a mark above the forehead?
There is ever so
No.
lightly though. No?
There's not above the forehead. Up in the back there is, but not above the forehead. So this baby was just deflexed OA. Make sense?
Right.
I'm getting a little confused now. Can you explain?
Okay,
the
what are you
last-
confused about?
So, like how deflexed OA?
Yep. Do you see the leading point at the top of the head?
Yeah.
Yeah. But there is no divot at the top of the forehead.
Okay.
Can you see the divot? There's no divot.
No divot.
Is there a divot?
Right. So
somewhere
here,
in
let's
the
go find one so you can see it again. Hold on.
beginning of the head?
Here we go. Look right here. Look at the top of this photo. You see the divot in front of the head? There was pubic bone pressure there. You see
Right.
here, see the divot above the bones?
Yeah.
Yes.
Pubic bone pressure, okay? So what I'm trying to show you here is that with this baby, there's no divot, which means it had to have filled the sacrum. The leading point is in the back, but not at the crown. It's at the top of the head. So that tells you flexion.
Right.
Okay.
So just do this yourself for a quick second. This will help you understand it. Do this yourself. Put your hand at the top of your head, right? Now flex your chin. You see how your finger has to go back and then deflex. That's the point of pressure. Can you see what I'm doing here? Like this. If my face is deflexed, this is the leading point. If I turn my chin, the leading point goes further back. You
Right.
see what I'm doing?
Yeah.
Yeah. So the leading point tells you the angle of flexion. And if the leading point is side to side, it tells you the angle of asyncliticism, right? So if this is the leading point, the baby had to have been asynclitic. If this is the leading point, the baby had to have been asynclitic the other direction, right?
Yes.
Yes.
Now it makes sense. Yeah.
Okay. Okay, good. But if there's marks here, the baby had to have been facing up. So let's keep going because these are kind of fun to look at. So how about these babies? On the right-hand baby, these babies were born about an hour apart. And the second baby was breech. By looking at the baby with the hairy head, can you tell that it has molding to the back?
Yeah.
That was an OA vertex baby. But the baby on the left has a long, smooth slope over the top of the head. That's breech molding. You see the difference?
Yeah.
This baby was just super fast, right? Third baby came out fast. How about this baby? What can you tell here? You see the ridge?
Wait, okay, this one. So back of the head, asynclitic, and
Yes.
is a divot. There's a divot right
Yep.
after the molding.
Yep. Which means this baby took the long arc rotation,
Right.
right? He eventually was born anterior, asynclitic, but that mark on the top of the head tells you that he sat in the OP for part of his labor.
Right.
How about this baby?
Wow.
This baby, not only do you see the divot, but you see that the forehead is also flattened and the leading
Right.
point is basically on the top of the head.
So
Yeah.
deflexed.
Yeah.
The top of the head is flattened because of the pubic bone molding it, smoothing it.
Yes. So not only did this baby sit OP for a long time, this baby was born OP.
The baby was rocked in OP till the entire forehead got smoothed over.
Exactly. Can you see it now?
Yeah.
Yeah. How about this baby?
Wow.
Can you
Just
see the pubic bone mark at the top of the head?
Yeah. Satin OP.
Yeah.
Born deflexed in, OA because.
No, not OA. There's no old molding here. There's no, like, crown of the head, basically right where her thumb is. There's no
Right.
molding there. The point of pressure, the leading point is the top of the head.
It's the top of the head.
And yet the forehead is not smushed down, which means this baby was not born vaginally.
Oh.
So going back to the question we had a little bit ago about CPD, this baby would absolutely get the diagnosis CPD, cephalopelvic disproportion. The nurse's thumb is basically at the sacrum, and the notch above the forehead is basically the pubic bone. That is too small of a space for this baby to fit through, right?
Oh.
Right? Can you see it?
So the smallest point was between the divot and the thumb, but then
Yeah.
that's beyond it, the baby's much bigger.
That's right. So this baby would get the diagnosis CPD. However, it is positional CPD. Even though this baby could not fit OP at all, if this baby were rotated into the OA and the face were filling the sacrum, there's a high likelihood this baby would have fit. And in fact, this mom labored for 2 days and pushed for 2 hours, and there was no progress, and we couldn't rotate the baby. We tried all the things, and so she was born by cesarean. But she was a family planning a lot of babies, and so she came back to me with her next baby and wanted to try for a vaginal birth. And I said, well, I'm so supportive, but you have to have a baby in the OA for your baby to possibly fit. So we did all the body work and all the spinning babies and all the positioning. And she had a 2-hour labor with a baby a whole pound bigger that fit easily because it was properly positioned.
Wow.
So positional CPD looks like CPD, but if the baby is OP, that is the reason. So in answer to the question about why do babies get diagnosed CPD so much, it's mostly positional. How about this baby? Here. What's the leading point?
Top of the head.
Top of the head.
Top of the head. See that pubic bone mark?
Yeah.
See the asynclitic mark? But see how in this baby, the forehead is basically flattened?
Yeah.
This baby came under the pubic bone in the OP presentation.
Wow.
Asynclitic OP, persistent OP. How about this baby? Can you see it?
Oh yeah.
Leading point,
Top of the head.
pubic bone mark in the front, and the forehead has been flattened coming under the pubic bone. And now you can see this baby in the OP. Yep. How about this one? What do you see here?
Face presentation.
So
Yep.
amazing.
I know, when the chin leads, right? When the chin leads, that's mentum anterior. But the only way for this to work is if the bulk of the head is in the posterior, like this.
Mm.
Here's another example. You see it?
Oh my God.
Swollen lip.
So it is extended face presentation, right? Which
What
is
do you
9
mean extended?
so like it is completely flexed, deflexed, military, and extended. So this is extended, which is face presentation.
Right. So when the head gets fully extended, if you tilt your head all the way back till it touches your back, then that becomes a face presentation. And the reason face presentations happen is because the baby started deflexed, and this is the smaller diameter.
Yes. Yep.
Yes. Here's one more example of that. With a beautiful intact perineum stretching perfectly. How amazing is that? Smushy little baby. Okay, this molding is very unique. This molding makes it look like there's 2 points of pressure, the very base of the skull and the forehead. Can you see that?
Yeah.
So if there was even solid pressure all the way along that line, what position would this baby have to be in?
Can you repeat that question, Augustine?
Point of pressure is the very base of the skull and the very point of the forehead.
Uh-huh.
If there was even pressure all the way along those 2 points to create this kind of smooth molding, what position would this baby have to be in?
Transverse.
Close. Breech. That's fundal molding.
Oh.
Can you see the fundal molding? Pressure all the way across. That chin is tucked to the chest, and the only available space, the entire top of its head, has pressure from the fundus. Yeah. That baby is just pretty quick. That one right there, that's fundal molding. Can you see that's a breech baby? Smooth all the way across.
Wow.
Yeah. This is an interesting one. What do you see here?
There are
Can you see
two?
Magna?
Yeah.
So what's that ring around the back of the head? Has a specific name. It's fluid filled. That's a caput or caput. You guys heard of that before? Caput?
Yep. Yes, keep it. Yep.
Yep. Yeah. So caput is a edema filled, fluid filled swelling. Why does edema happen on the baby's head?
If there is pressure at a particular point.
That's right. So the indent around that ring is the pressure from what
Vacuum.
of the mom's? No, although that can make it.
Pelvic bone.
Nope, bones don't make edema. Bones make bruises.
I'm sorry, I missed that question.
This ring around the
Uh-huh.
baby's head is created by the cervix.
Mm.
So there's two marks, bumpy marks on the baby's head that you could examine. One is called caput and the other is a hematoma.
Uh-huh.
Hematoma is caused by bones. Caput is caused by soft tissue.
Oh,
Okay. So a hematoma is a bruise from slamming into mom's pelvis. A caput is swelling from being held back in mom's cervix.
so which of this is a hematoma? This is the top, just above the forehead.
Nope, way in the back, that ring around the whole back of the head.
That's the hematoma caused by the pubic bone.
Nope, caput caused by the cervix.
Caput caused by the cervix. Okay.
But how can the caput be caused by cervix?
Because the cervix is firm and unyielding.
That means any lip, anterior lip.
Nope, not even anterior. This is about a 7-centimeter caput. You see all the way around the head, there's a nice firm ring and a bubble basically formed above it. That bubble is the caput. And the ring is the cervix. The baby's head was coming through the cervix, but the cervix stayed and stayed and stayed and stayed and formed this swelling.
Oh,
Is
you
it
picture
because
it?
of the mother pushing for a long time with a 7-centimeter dilatation?
If she was pushing before she was fully dilated, that could form a caput.
Okay.
Just strong contractions could form a caput though.
Okay.
If the cervix was unyielding. So primips are more likely to have caputs than multips. And multips are more likely to have hematomas because they kind of throw their baby through their pelvis, slam it into a bone, and spit it out. So this picture is just kind of curious. I just like to show a picture of a caput, but more than that, I want to take us off topic for a quick second and tell you that this picture is the perfect example why we don't do preterm breech. So you see how this baby has very thin kind of skin. You see how he's got lanugo across his back. He looks a little premature, like 34, 35 weeks. Can you see that?
mm-hmm.
Also, the position of the shape of his head compared to his bum is disproportionate.
Mm-hmm.
This is a baby that if it were born breech, and it was not, this is definitely head molding from a head down baby. But I want you to imagine that 7-centimeter unyielding cervix. Can you see the bum would fit through that,
Right.
but the head would not?
You need the hard bony head to mold through. and
If
be
you have a
wide.
premature baby, even slightly premature, if you have a primip and an unyielding cervix, head down is the only safe way to do a vaginal birth.
Right.
So the only risk with breech delivery, I mean, truly, other than any other normal birth risks, the only real risk of breech delivery is entrapment of the aftercoming head. Once it's in the pelvis, I can teach you to get it out. What we can't solve, though, is if it's still in the cervix, if the body slips through a not fully dilated cervix and the head is trapped behind the cervix. You cannot solve that. Nobody can. You can't pull the baby up. You can't get a hand in. You can't push the baby back. Even cesareans don't really save those babies. Okay? So if you're thinking about adding breech to your practice, please, please, please don't do IUGR or preterm breech birth ever. That is an absolute reason for a cesarean. Make sense?
Yeah.
Okay. Can you see this capit on this baby's head in the lower right of the picture? That's about a 4 centimeter capit.
That's a
Can
vacuum.
you see that? It looks like a vacuum, but vacuums are bigger than that. This is a 4 centimeter capit.
Okay.
And it's off to the side because that baby was a little asynclitic. This is a hematoma. Smoother, and it stays longer. It's like baby 2, day 2, and there's still a hematoma. When you go to do vaginal exams, please take a nice long time. Feel everything. Feel the position of the baby. Feel the shape of the cervix. Feel the station. It takes as much as 30 seconds for your gloved, lubed fingers to even warm up to the temperature of the vagina so that your proprioceptor receptor sites on your fingers can even tell what they're feeling. So if you're going to do a vaginal exam, take as long as you need to really get all the data so that you can make good decisions and you can help your client make good decisions. So all babies enter the pelvis in the transverse, like in slide A, and they either rotate into the anterior in B or into the posterior, like C. So discovering malpresentation, we need regular prenatal care. We need to see them weekly at the end. We have to have excellent palpation skills. So if you haven't developed that, work on feeling every baby you see, every belly you see. Encourage your mothers to do belly mapping so that they become better and better at knowing their own baby's position. Teach optimal fetal positioning to everyone. Really master that internal check so that when you do feel, you can determine position. And for primates, VBACs are all post-dates labors. Checking their cervix isn't a bad idea somewhere in labor, maybe when they check in or somewhere in the midpoint, so that we make sure that we find those babies that are tending to rotate towards the posterior and help to solve them and or have patience with them. And if there's a labor plateau, a dysfunctional labor pattern for that woman, or abnormal pain, all of that is trying to tell you to pay attention to a malpresentation. So again, this rotation towards the anterior is what we are going for. So if we find a malpresented baby, we want to figure out the goals of treating them. So the baby's goals, the first most important need, is to disengage that malpresentation from the pelvis. And of course, before we do anything, the mother has a need to gain consent and understanding of what's going to go on before we continue. So assess the lie, presentation, position, flexion, and syncliticism of the baby, and assess fetal heart tones throughout to make sure that they tolerate all the activities that you're doing. And assess, correct, or treat any calorie deficiency, any hydration or electrolyte imbalance. If her uterus is malpositioned, we have to correct that too. And if she's got infrequent or not strong contractions, we have to solve those. And then lastly, we might release any barriers to the baby descending, like a tailbone or breaking her water. But that's the very last thing that we do. So if you discover a malpresentation pregnancy, the mother is the best alert system for this. She can tell you she has kicks out front, or she's got back aches, or something doesn't feel right. Spend as much time as you need to be sure of what you feel. Use spinning babies as an excellent resource for techniques to move the babies, and that's spinningbabies.org. .org, I think, maybe .com. Teach optimal fetal positioning, encourage women to be upright and active some part of every day, teach posture and how to rest the pregnant body, send them to chiropractic, especially chiropractors skilled in the Webster technique, but really any body work is helpful. Homeopathic treatments could be helpful, like her constitutional remedy or pusatilla. Be proactive. It's always easier to move a floating baby than once they're engaged in the pelvis. And when you aren't clear, you can order an ultrasound to be sure, although many ultrasounds fail to report on actual head position. If you don't discover this until early labor, there's some things you can do in early labor, like the rebozo techniques from Central America, where mom is on her hands and knees or standing upright, and we use a big cloth to shake or shimmy or even bind her belly. Spinning Babies has lots of techniques like the knee chest or the inversion, slant board, stairs, all those things. And then there's lots of midwifery textbooks that teach about different positions, like I call the rotisserie chicken, but it's technically called Miles circuit, or using the birth ball or Walters or the stomp squat techniques. And again, all of those could each be researched into workshops, so we're not going to go into. If you don't discover it till active labor, the most important piece is disengaging the baby. This is the most important piece for success. And so we want to basically get an inversion. We want to get her pelvis higher than her belly without a contraction, between contractions, so that the baby can disengage. So this is my redo process for active labor. If you don't find it until active labor, this can be incredibly helpful to cause the baby to rotate. So before you do anything, if she's having a ton of back labor, you might consider the sterile water papules. If you don't know about this, I have a video on my Instagram account and my Facebook account if you want to go watch how to do sterile water papules. It's very easy. Anyone can learn how to do it. Wait for about 5 contractions for it to take effect because it has an incredible pain relieving effect for the back. Then can do sideline release for 2 contractions each side. So we'll do sideline release for 2 contractions on the left and then sideline release for 2 contractions on the right. Then you move her into knee elbow. So she's on her knees and she comes down from her hands to her elbows for 2 contractions while we shimmy and shake. We call it shake the apple tree. You put a rebozo across her bum and jiggle, 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 jiggle to help move that baby out of the pelvis. Then you do a supported open knee chest position for 2 contractions. And if you want, we can send you the link for this technique online. And then we do sideline for 2 more contractions, whichever side the baby is to move, we move her to that. And then lastly, we get up and do lift and tucked for 10 contractions. It could be more, could be less, but usually what happens is mom gets a real relief of pain and suddenly she wants to bear down. And that is that beautiful movement that happens. And this is a 20 contraction routine. So it takes an hour, sometimes 2 to get through this, but it causes a really quick relief for the process. If you don't discover this until second stage, when she's already pushing, the first thing that we want to do is right the position of the baby and or the flexion of the baby. So this could be any of the techniques we've already talked about. It could be actually putting your fingers in and helping to reassess or move the baby's head. The next thing we want to do is right the position of the uterus. So we can use binding, belly binding, rebozo, blocks, positioning of the mother, all kinds of things to help her uterus be midline. And then we would deal with any cervical lip or a baby who's still high. So stomp, squat, or pushing the cervix back, only if the first 2 pieces are done. And then lastly, we could break her water and teach her how to push. But we wouldn't want to do that until the other 3 steps had been done because we won't want to wedge a baby lower in the pelvis that is malpositioned. What fun. Well, thanks for joining, everyone. I do these occasionally, just as like, I think there should be more midwives in the world and I want to share the wealth. So if there's a topic you'd particularly like to hear on, if this was useful to you, please send me a message. I'm on Facebook under my name, Augustine Colebrook. I'm on YouTube under my name. I have a bunch of videos up there. This will eventually end up there. I have different social media platforms. And then I have a whole online teaching platform at midwiferywisdomschool.com. So if there's a topic you'd like to have a presentation on, please don't hesitate to ask for it. I love to share my knowledge. And if you ever find yourself in Southern India, come visit. We have a fun thing going on there. All right, everyone, have a great afternoon. Take good care of yourselves wherever you are. The world needs you desperately. We need more midwives. So we need you. Take care of yourselves. All right, everyone, have a great day.